Hi, everyone. Thanks so much for joining us for a special Ask the Experts Facebook Live Q&A. January is Cervical Cancer Awareness Month, and we have two of Moffitt's gynecologic oncologists here today to answer all of your questions. Joining me are Dr. Robert Wenham, gynecologic oncologist and chair of the Department of Gynecologic Oncology at Moffitt Cancer Center, and Dr. Jeannie Chern, gynecologic oncologist here at Moffitt as well. Thank you both so much for being here. Before we get underway, just a few quick reminders for our audience. Please submit your questions in the comments section, and we'll do our best to get to as many as possible. And please keep in mind, we cannot make personal diagnosis or offer medical advice via Facebook. Additionally, Facebook is a public forum, so any comments or questions asked here are visible to the public. So Dr. Wenham, Dr. Chern, thanks again for joining us. We'll start with some questions here. Dr. Wenham, we'll begin with you. What are some of the causes of cervical cancer?
The number one cause is actually a virus out there that's called human papilloma virus. It's responsible for the vast majority. Cervical cancer typically comes in a couple different forms. There's ones we call squamous cells, which are more often developed on the outside of the cervix. And then there's ones that are adenocarcinomas that develop on the inside of the cervix. There are some very rare types and that are out there, but they don't really constitute what most people think of when they think of cervix cancer. So those two more common types are typically caused by something called HPV, or the human papilloma virus.
About how many types of cervical cancers are caused by HPV?
So, well, there's approximately 12,000 to 15,000 cases of cervical cancer a year in the United States. Fortunately, we've seen a little bit of a decline with the advent of Pap smears and the use of vaccines. But it's important to recognize that worldwide, this is still one of the biggest cancer killers of women, and so unfortunately, it disproportionately affects women of third world and second world countries and of lower socioeconomic status sometimes.
Dr. Chern, I'll ask you, what kind of tools do we have available to prevent cervical cancer?
That's an excellent question. So, as Dr. Wenham mentioned, there are things including Pap smears and vaccines, and I think once you get a cancer, the cancer is already there. And so what we at G1 Oncologists, we want to prevent cancer. And so prevention is the key. So we talked about vaccinations. The best preventative that we have is to get vaccinated. In the US, we have a 9-valent HPV vaccine. What that means, it covers 9 viruses. They include the low and high risk viruses, which causes cancer. There are many versions, as you guys know, but commonly the two histology types that Dr. Wenham mentioned is usually caused by either HPV 16 or 18 being the most common. The other thing about vaccines is that it not only prevents cervical cancer, it also prevents vaginal cancers, vulvar cancers, anal genital cancers. It also prevents head and neck cancer. So it not only covers women, but it also covers men. We can vaccinate children as young as 9 and up to age 45. But the younger you get vaccinated, the better effect that you're going to have. So you can prevent these cancers by doing this as soon as it's possible. And then outside of vaccines, the way we kind of follow and prevent cervical cancer is to do Pap smears. And so that's, making sure you go and get your well woman exam with your gynecologist or your primary care provider, whether that's your family physician, your internist, your nurse practitioner. They can do a Pap smear, and it allows us to detect precancerous cells early.
That's great. On that note, I have one I'd like both of you to kind of weigh in on. The director of the World Health Organization recently put a call out to use those tools, use the vaccines, use the screenings. Let's end cervical cancer. Is it a disease we can really end? Dr. Chern, I'll let you start.
Yeah, I often will say this to my patients. It's probably one of the few cancers, or the only cancers, at least in GYN, that we can quote unquote cure. We can prevent this cancer. If you detect it early, you can treat it. And if we were to be very proactive and screen patients early, find these precancerous lesions, hopefully that's something that we'll be able to reach in the future to eradicate cervical cancer.
Dr. Wenham, anything to add?
Yeah, we're so fortunate to live in a time where we can actually prevent a cancer with a vaccine. Who would have thought this, 40 years ago? But the problem is really getting it taken. Unfortunately, once again, women who are more socioeconomically challenged tend to get it at a lower rate than the ones who would be coming in normally for all their checkups and exams anyway. So it puts them at double risk. First of all, they're not getting the same degree of intensity of screening through PAPS, but they're also not getting the opportunity to have preventable illness with vaccination. We could, if we wanted to, in our lifetime, get rid of this cancer. It just takes the will of both our patients and our society in general to make it happen.
Great, thanks so much. And again, if you're just joining us, our experts are here answering all of your questions on cervical cancer and for Cervical Cancer Awareness Month. So we've got some great questions coming in from the audience. Viewer Juanita asks, she has already been treated at Moffitt for cancer. What are the chances her cancer would come back, and how does she know? I assume she's asking about cervical cancer. Dr. Why don't you take that one?
I'm happy to do that. So, there's a lot of specifics to that just we don't know. And so, but what I will go back to is like, what is the probability that we take care of cervix cancer from its diagnosis? And fortunately, we find most cervical cancer stage 1, and stage 1 simply means limited to the cervix. And the vast majority of those are going to be cured if detected and treated appropriately. So that's the good news side of it. And one of the reasons why most cervix cancer out there, doesn't get as much highlight as like ovarian cancer. It's just because the stage is caught a lot earlier. The unfortunate thing is that those cancers can come back. When they come back, they can be particularly challenging to treat. The good news is that the number of treatments has been multiplying lately, but I'd still rather prevent a cancer in the first place. I'd still rather treat it when it's early. So don't think about these other things as fallback mechanisms.
Dr. Chern, I'll ask you to kind of expand on Dr. Wenham's comments about treatments. What sort of treatments do we have available for cervical cancer?
Excellent. So, early stage cervical cancer is usually treated either one of two ways. It can either be treated surgically if it's deemed appropriate, and this may include a procedure called a radical hysterectomy. What that means is the removal of the uterus, the cervix, and the tissue right outside the uterus, outside the cervix. And then also it includes the removal of some lymph nodes in the pelvis. In patients where they have cervical cancer and surgery is not deemed appropriate, then the treatment is generally a combination of chemotherapy and radiation. But I think also important thing I should also highlight is that at a cancer center like ours, other options include clinical trials, and we have clinical trials that address how we can treat patients either with early stage disease or even advanced or recurrent stage disease.
I'd love to hear more about clinical trials. What feel free to get into the specifics of what exactly those are, what sort of things we're working on here at Moffitt.
Sure, I'll highlight a couple, and then maybe Dr. Wenham would like to expand on some of them. So currently at Moffitt, we have several clinical trials directed for cervical cancer. We have them in the upfront setting, meaning in a patient who's just newly diagnosed early stage cervical cancer. We have a chemotherapy plus a additional drug that could hopefully prevent the growth of that tumor with the treatment of radiation. We also have a couple of trials looking at recurrent cervical cancer, and one of the trials is Dr. Wenham's trial, the TIL study, which is looking at patients' own tumor infiltrating lymphocytes to also treat recurrent cervical cancer. And then there's a drug combination using newer therapies that are available outside of chemotherapy called immunotherapy. We have a trial that focuses on that as either a single agent or a combination treatment to also help those patients with recurrent cervical cancer.
Yeah, I'd love to expand on that because, unfortunately, as gynecologic oncologists, Dr. Chern and I see a lot of patients who already have cancer, and the unfortunate part also is the ones that we're seeing commonly are the ones who have problems with their cancer, which means they typically have metastatic or recurrent disease. I don't know if I answered that last question enough, because I don't want to discourage anybody who has cervix cancer and feels like they have symptoms. They're going to put it off now because they have bad news. It's not stage 1. We can even cure limited stage 4 disease to the pelvis at least 50% of the time. So that's a pretty strange number when it comes to cancer. You have a stage 4 cancer that can be cured that often, but it's those ones that have disease outside the pelvis or the ones that have recurrent disease after we've tried to treat them. And for those patients, we haven't found really any curative kind of strategies. We can try to push the ball down the road and help them live longer and live better. I'll back up a little bit and say sometimes when there's recurrent cancer, there's just a little cancer that's recurrent to the middle of the pelvis and nowhere else. And we do specialize in a particular procedure, which can still cure about 50% of women at that point, but it's a very radical procedure. We're often taking out bladder and colon and bowel and recreating parts of the body, and so to speak. It's called a pelvic exoneration, but we do have that expertise. We'd rather not have to use that. Again, I want no cancer to begin with. I want small cancers to treat, and I want to have success. For metastatic disease, when we're talking about trials, immune therapy is really taken front stage. And the other thing that's taken front stage for research are these, what we call antibody drug conjugates. And I'll explain a little bit of both of those. Immune therapy can mean a lot of different things. It can mean everything from an antibody that we give somebody that helps reactivate their immune system so it can recognize cancers. There are new molecules that can actually stimulate directly the immune system while holding on to the cancer cells. There are cell therapies where we actually take either someone's own immune cells or some modified immune cells and give them back to the patients and get a response. There have been approvals in the last year or two of immune therapy. And so we know it's active in this disease. We're trying to figure out all the right people to give it to and the right combinations. So it's a place where we actually have a lot of trials now for various people. We have also some radiation sensitizing drugs out there. We have a drug called triapine, and we're working with cooperation with the Gynecologic Oncology group to test this drug to see if it can make the success of initial treatment with radiation even more successful. So I think, to me, I'm extremely excited about where we're going to be with cervix cancer over the next 5-10 years in treatment. I'm disappointed at where we could be as far as preventing it. So.
Great stuff. Thank you both. We're getting tons of great questions from our audience. If you're just joining us, we have our experts here answering your questions for Cervical Cancer Awareness Month. Be sure to keep questions and comments going in the chat. Just a reminder, we can't offer personal medical advice or make a diagnosis via Facebook. Also, it's a public forum, so any comments or questions here are visible to the public. With that, our next question comes from Elizabeth, and she asks, can locally advanced cervical cancer be present if yearly Pap tests have been consistently normal, but HPV has only recently been detected? Dr. Chern, like to take that one?
Sure. So let me just rephrase this question. Can you have locally advanced disease if you're getting, annual Pap exams? And so, the short answer is during that Pap exam, your physician should be really looking and evaluating the cervix. And if they see a large mass or a lesion that looks abnormal, generally speaking, outside of doing a Pap smear, they should be biopsying to identify whether or not that's actually a cancer or just abnormal cells. So, sometimes we don't really rely just only on a Pap smear, but it's that thorough pelvic exam or a thorough well woman exam to see if there's something abnormal that's found, visually found, let me clarify.
Mm-hmm. And on the topic of Pap smears, we've actually got two sort of similar questions. Viewer Pam asks, after what age do you recommend not getting a Pap smear? And Jean wants to know, can a person over the age of 45, I'm sorry, that's a different question. We'll start with Pam's question. What age would you not recommend getting a Pap smear? Dr. Chern, go ahead.
Sure. So, in general, currently the ASACP guidelines, which is kind of the governing body for making these guidelines for how often should you get Pap smears. There are other governing bodies, the American College of OBGYN and the Society of Gynecologic Oncology. In general, you'll continue to do Pap smears until about age 70. And if they continue to remain negative, then you can discontinue. Now, if you have a long-standing history of abnormal Pap smears or dysplasia, then you may continue to follow that a little longer. If you have a cancer diagnosis, that when you stop doing those things, that may also change too.
And you actually touched on a topic I wanted to get to, dysplasia. Dr. Wenham, I know we've chatted about offline. There's a new dysplasia clinic at Moffitt. If you could explain to our viewers, what is dysplasia and what can you tell us about the new clinic?
Yeah, dysplasia represents an opportunity to stop things before it's cancer. So it's the smoke before the fire, if you will. Dysplasia are the altered growth of cells that are visible before those cells have invaded into the body. So once there's invasion, that's the difference between dysplasia and invasive cancer. And it comes in varying degrees. So you can actually tell by the level of dysplasia, the risk of having an underlying cancer. And that's when you have a pap smear, what the person looking at that pap smear is looking for is cells that just kind of look bizarre. So dysplastic appearing cells. And then what we have to do is do tissue biopsies to actually look at the architecture of those cells together to determine whether or not it's high grade or low grade dysplasia or whether it's invasive cancer. And so, and the problem with pap smears, I think that question came up before, is can you have cancer when you've been having normal pap smears? The answer is yes. Pap smears are only about 50% good at finding cancer. But the good news is that they're much more effective at finding precancer or dysplasia than they are finding cancer. And it's that series of pap smears being normal that really helps you. HPV is added to that. So a lot of times HPV is done if there's any kind of funny looking cells at all as a reflex thing. And there may be on the horizon the elimination of pap smears coming up and replacing that just with HPV testing.
On that note of patch fear and HPV, Kim asks, if you get a pap smear and have HPV, will it go away or can it come back again? I'll let you take that one, Dr. Wenham.
So yeah, HPV is typically cleared by most women. So that's why we don't see more, because HPV is out there much more common than positive HPV tests are, and much more common than dysplasia. So most HPV infection will not result in dysplasia, and most dysplasia will not result in cancer. So that's the good news part of it. Your immune mechanisms are supposed to clear this, and you can actually get infected with different forms of HPV over time because there's many different types, dozens of different types. So for some women, it's hard for them to clear for one reason or another. We know one of the things that can contribute to that is just basically a poor health status. Some immune deficiency diseases can do that. Smoking, I will say smoking a third time, really increases the rate of dysplastic cells and the rate of cancer. So it's just one of those things that we see it much more frequently in people who smoke, unfortunately, because some of the carcinogens happen to act in concert with the other cancer-inducing mechanisms. So hopefully that answers a little bit of the question.
Mm-hmm. Thank you for that. You mentioned smoking as a risk. We've talked about HPV. Dr. Chern, I'll ask you this. What are some of the genetic risks that are associated with cervical cancer?
It's an excellent question because, when we talk about cancer, we now are really looking at very personalized medicine, personalized treatments based off either tumor genetics or the patient's own or germline genetics, meaning genetics that they're inherited. So currently, there's really no well-established model that looks at the genetic basis of cervical cancer. There are some population studies that have looked into this, and maybe it's because they're unable to do exactly what Dr. Wenham mentioned, clear the infection. So they're more prone to these HPV infections. But there are other, tumor biology markers. I'll call them. They're markers in cervical cancer that we're looking into, but currently there isn't a gene that specifically causes cervical cancer itself.
It just seems like there's genetic links to almost every cancer out there. Why is it so important to just be aware of your family history?
I think it's important to kind of know your family history for two reasons. One, as we're really understanding the biology of cancers now, many of that is related to that gene. And so outside of cervical cancers, there are certain cancers, particularly, I'll step a little off topic, ovarian cancer, for example. The BRCA gene is very well known, well established in ovarian cancer, and there's a role in treatment. And so that's treatment for the patient with that cancer. But importantly, knowing that family history, that's also important for other family members. So we'll go back to that prevention. So if you know the history and you identify genes that may ultimately affect you, you can prevent yourself from developing that cancer by undergoing risk-reducing strategies.
Great answers. Again, if you're just joining us, we've got our experts here answering your questions on everything cervical cancer related for Cervical Cancer Awareness Month in January. Again, we cannot offer personal medical advice or make a diagnosis over Facebook. And remember, it is a public forum, so any comments or questions asked here are visible to the public. So great questions. Keep them coming in the comments. Next one comes from viewer Amy. She asks, as a cervical cancer survivor, HPV related, would she be at a higher risk for developing other HPV-related cancers? Dr. Wenham, I'll let you take that one.
Great, because HPV is not just cervix cancer. HPV has also been associated with anogenital cancer as well, so cancer of the anus, as well as cancer of the upper respiratory tract, particularly the larynx and the esophagus. Or head and neck is what some people just refer to that as. Interestingly, it's different kind of the role it plays in each one of those areas, but yeah, you can be at risk of others if you've been exposed similarly. And again, smoking actually compounds the risk of those. And in fact, the ones that are smoking induced to the head and neck are actually harder to treat than the cancers that have HPV to them as their cause.
Dr. Chern, I think I started to ask you this question before, but turned it around on you. But Jean wants to know, can a person over the age of 45 get the vaccine? I assume they're meaning HPV vaccine. If your GYN recommends it, if not, why?
So, the current FDA approval is from age 9 to 45. The previous approval was up to age 27. It was that, and to my earlier point, it's when you get vaccinated earlier or younger, it creates this immune, a nice robust response. The older you get, we don't know that it's going to be as effective. And also you might have already been exposed to that virus at some point. And so, the benefits tends to decrease after 45. Now, whether or not you can get it, that would be something I would say, talk to your provider, whether, your gynecologist or your family practitioner, see if they would be able to get that vaccine for you. There are some circumstances, patients who are immunocompromised would be someone I would say may consider getting it, especially if, currently you're testing negative and there's no HPV that's being shown. But those are things I would say, talk to your well-woman physician to see if you qualify.
We've got a two-part question here from Sarah. Dr. Wenham, I'll give this one to you. She asks, are women who have had children at higher risk of cervical cancer? And then part two is, what about oral contraceptive use?
Oh, wow. I love these questions. I'm trying to think about how far we want to dive into them. So the risk factor actually for cervical cancer is really exposure to virus. So to make it easier, so children themselves are not necessarily a risk factor. If those children with multiple people, then obviously your exposure is greater. I mean, if you're somebody, and you guys have had limited partners all your life, your risk is much lower despite the number of children you have. Oral contraceptive pills were somewhat controversial because for a while we were seeing an increase in the adenocarcinoma types rather than squamous cell cancers. And it was originally thought it was around the time when birth control pills were high dose and first coming out. I've looked at that data a few times and given talks about it. I think the effect of that is overall probably pretty small, and really the effects were much more involved with the serotypes of HPV ratios that we see. So 16 is more favoring squamous, 18 favors adenos. We've been seeing a shift in the type of viruses out there, and that's probably more to explain it. Also, the uptake of pap smears. Pap smears are better at detecting squamous cell abnormalities than they are the adeno ones, which are more hidden inside the cervix.
You mentioned age there. Viewer Angela, she asks, what is the earliest age that this type of cancer can occur?
I don't know if there's a limit, but I know that typically you can see incubation of the virus for up to 10 years before you see overt cancer. Now, and there are some populations that you can have a very rapid progression of cancer. So let's say you have a juvenile patient with full-blown AIDS and they've had exposure to HPV, they would be at risk of developing a rapid progressive cervical cancer. So you can see it much younger, but we typically don't start seeing it until later, which is why the new pap smear guidelines and recommendations are to start pap smears around the age of 25 now.
Dr. Chern, I'll give you this one. Viewer Tara asks, simple one, how do you get HPV?
So HPV is usually transmitted through some type of bodily fluid contact for the most part. So of course, this kind of leads us back to how does that happen? Often it's usually through some type of sexually transmitted mechanism. So, whether that's oral intercourse, vaginal, penile intercourse, any of those types of interactions can increase your risk. It's different than things that we think about with other viruses such as HIV or hepatitis. So that often is not just, fluid transmission, but also blood transmission. So HPV works or is transmitted a little differently than those other sexually transmitted infections.
Seems like we have all the questions from our audience for today, so we'll close things out. It is Cervical Cancer Awareness Month. Just, parting message. What do you want our audience to be aware of when it comes to cervical cancer? Dr. Chern, we'll start with you.
Sure. I think the take-home message is, prevention, prevent cervical cancer. If you could do that through vaccinations and healthy, well woman exams, that's the way to go. If you have high-risk behaviors, including tobacco use, smoking, quit now. It prevents not just cervical cancer. There's other cancers that are related to HPV, but other cancers that are not related to HPV is also associated with tobacco use. So, prevent the cancer from forming. I agree. I agree with Dr. Wyman. I'd rather prevent than actually treat the cancer itself.
Dr. Money?
I think that's great. And I would further throw in, this is going to seem self-serving. And so I'll just say that up front, but it's not. Maybe it's self-serving in the fact that I don't want to see patients who have cervical cancer have problems that maybe could have been avoided. But really, your first chance is your best chance at treatment. And so the very first workup, the very first treatment plan, the very first expertise in either delivering radiation or surgery or the combination thereof can make all the difference. It's not always possible to go back and do a redo. So my advice to everyone is, if you know somebody who has cervix cancer or looks like they might, get them to see a place with a high degree of expertise and specialism so we can give them the best chance.
All right, great note to end on. Dr. Chern, Dr. Wenham, thank you both so much for taking part in this today. And thank you to all of our audience members. Fantastic questions. Thank you to Sarah and Jeremy behind the scenes helping put this together. And if you want to learn more about cervical cancer, please visit moffitt.org.